All right, thanks very much for that introduction and for the opportunity to speak. As you said, I'm kind of bringing together several different backgrounds, taking them in the wild. You may decide that I'm lost, we'll see. And apologies to the interpreters for how fast I'm probably gonna speak to get through this. And so, I'm really interested in developing better tools for tracking movement in the clinic. And, in rehab, we very much focus on improving motor outcomes, but we really don't have the tools to measure it routinely. And I'm particularly interested in walking as a physician. How someone walks in and out of my clinic tells me so much about their health status, but we're typically lucky if we even measure their walking velocity. And we certainly don't capture the kind of phenotype of a frail gait and the people that are at risk of falling and Trendelenburg gaits, other than what we write down in our clinical notes. And there's a lot of promise from the techniques that are being developed in human pose estimation and computer vision, but I'm going to talk a little bit about how these are really challenging, partly because they're rapidly evolving, which is good, but makes them technically challenging. They're not really designed to produce clinically relevant outputs, and I think that's partly on our field to speak to the computer scientists and push on them. And they're often not validated in clinical populations, and also we don't necessarily understand their reliability, and really that's critical for having any kind of trustworthy and explainable AI that you'd want to use in clinical decision making. And so to address some of the challenges that I mentioned on the technical side, one of the first things I did when setting up my lab was develop this tool that's open source called PosePipe. And I won't talk too much in detail, but what's nice is it builds on this other tool called Data Joint that was developed in my grad school lab. It gives a database backend with Python and MATLAB front ends to handle running analysis on all these data. And in this system, we're holding like 50,000 videos. We can easily develop a new algorithm and run it on tons of people. One of the critical points I do want to highlight is that when you're in the clinic, often there's therapists around, there's other patients around, and you really need to be able to say, I want to analyze this person as opposed to the other people. And so even just having the tools to run a tracking algorithm, identify the bounding box, and then run some of these algorithms that I'm showing here is really quite useful. But for the majority of this, I'm going to be talking about approaches that actually go from 2D key points of the person that's of interest and lift them up to 3D inputs. And below, you're seeing the sagittal view of the person walking. And if you look at that by eye, okay, I believe that looks like walking, right? But it doesn't really tell us what we want already. So we don't know when the feet are coming on and off the ground. And it turns out because of the scale ambiguity of of cameras in general, we don't really actually have calibrated distances there. And it turns out also the joint angles are pretty terrible. Okay, that sucks. But on top of that, there's also the problem that these approaches don't really tell us much about the reliability. So the 2D key points do actually give some confidence intervals, but when we go to these 3D approaches, they tend to not. So I just kind of want to give a shout out to this work with Pavel that was working on using graph conditional normalizing flows in order to actually get valid probability distributions on these lifted joints. So I just told you how these things don't produce useful outputs. So how are we going to actually translate it into useful outputs that we could actually use for gait analysis? And we're just going to kind of lean into the problem. So we're going to use deep learning and train a transformer to map these kind of limited outputs, give some additional demographic information, including the height, and then using data from 1,000 videos, almost 10,000 videos from 1,000 individuals in our gait lab with simultaneous motion capture data, we train the system to kind of correct for these problems in the computer vision. And coming out of the system, then we produce the sagittal plane, hip and knee joint angles, as well as foot position, pelvis velocity, foot velocity. And also very critically, we have these quadrature encoded sinusoids that represent the phases of the 4 key gait events, so foot down and foot up on each side. And so we can get that, and you're kind of seeing there, we can now interpretably detect each individual gait cycle and then actually extract parameters from that. And there's some details I won't get into in terms of the common smoothing, which allows us to interpolate those phased outputs with subframe resolution, which is quite nice, and then trying to add some physical consistency to make this pretend that it has a model, although ironically, I'm in a session about modeling. There's no model here. It's just copying someone else's model. But, here's a video. It looks like it's doing pretty well. If you look at the ankles, that's the first thing I'd call your attention to. They're changing color when they hit the ground correctly. Those sinusoids look like the way they should. And for example, if you look at the child in the upper right, you'll see they're walking with a crouched knee gait, and you don't see much variability in those knee angles. But the child on the left, conversely, has a lot more range of motion. And when we go and look at the data that we collected, or I should say, Tezos collected over the last decade, and cross-validate this and look at the performance, we see that the timing accuracy is quite good. So about 25 milliseconds median error. So nice that we're getting to that sub-threshold or sub-frame rate resolution, and that we have a pretty good correlation for both these spatial parameters as well as these temporal parameters. However, for any AI algorithm, you really need to see it tested the way you want to use it. And I don't want to use it in a gait lab. That's the whole point. And so how do we actually see if this works in the wild? So Actually, this is what I like to call the portable biomechanics laboratory. I started developing these wearable sensors while I was in residency because didn't have the funding to buy any of them, and also none of them worked over Bluetooth. So we developed these systems. We can actually now record synchronized video with the wearable sensor data that's streaming over Bluetooth. I'm not talking about my EMG biofeedback work here, but there's a bendy, flexible version of this, and you can see on the backside there's EMG electrodes, and so stick that on the arm, and then we can measure EMG. And then typically we use a gimbal just to make the videos more aesthetic when we take them into clinic, and we can use this to record data. And so I was really lucky early on my lab that this resident, Trey Cimarelli, who's now actually on faculty and continuing to work with me, he was wanting to test this out, and he's a prosthetist. So he's like, let's test this in the prosthetics community, which turned out to be a brilliant stress test of this system because there's a lot of differences between the visual appearance of prosthetics and intact limbs. And they often walk with pronounced gait abnormalities. And so here's just some examples showing you that at first pass, okay, it seems to work, right? And you'll notice in the videos that are indoors, people are walking over black tape. So we put tape on the ground so that we could actually annotate the 10-meter walk test. And the people are also wearing the wearable sensors that we developed. And so here I'm just kind of showing a simple heuristic that detects the swing phase from the gyroscope. And we can then correlate that swing phase with the actual swing phase that's detected from the computer vision. And then of the hundreds of videos we got, I'm going to talk about 80 videos that were recorded in the frontal plane from these people. Trey did a great job of annotating a bunch of other properties, such as the prosthetic type and such. And here's the initial data. So the panel on the left is showing you, yeah, your left, good, same as mine actually. So the panel on the left is showing the correlation between the annotated walking velocities and the computer vision velocities, doing pretty well. And the next panel over is showing the cadence, which again is pretty well, but interestingly, there were some steps it's missing. And the histogram of the error shows a median timing error with the residuals compared to the sensor about 70 milliseconds. But if we then take the ones where the computer vision actually accurately detects the ankle in terms of its reported confidence, then we see that the cadence is almost perfect and our median error is 45 milliseconds. So what's going on? So I want to take a brief moment to talk about AI and fairness for people with disabilities. And so there's a lot of really important research happening right now in the AI field focused on fairness, but I don't think there's as much advocacy for the people with disabilities and their prevalence. And so they're often underrepresented in these data sets, which creates a number of problems. So for example, those two panels I'm showing on the left is a computer tracking algorithm, ironically called Fairmont. And what I found is if you actually give a child a rolling walker, it doubles the chance the computer vision fails to see that person. So I really hope that's not in any cars. And you can see, like, from the fact that it's 15, it's already fractured that many times, but other algorithms work quite well for this particular problem. And then similarly, when we use computer vision and we look at people that have bilateral prosthetics or bilateral transfemoral prosthetics, you can see a lot of noise in the key points. Thankfully, in this case, there's ways to easily work around that, such as using deep lab cut and training a custom model. And Trey did a great job of really looking at the performance of these algorithms pre-trained on large data sets, showing that as you have someone with a more proximal amputation or a more bilateral amputation, that it performs worse, particularly if the prosthetic is visible. But thankfully, in this particular problem, we can use that deep lab cut decoder, and we can actually restore the performance of our system and get pretty nice tracking of most people. And so what's nice is now that we can use this routinely in clinic to longitudinally monitor people. And so on the left, you're seeing that we can detect this improvement in cadence, which is not typically measured. You can see when they transition from a walker to a quad cane that they actually slowed their cadence. And then, the velocity kind of follows suit. But what's nice is on the far right, we can see even on that last session, when they're slowing their cadence and their velocity, they're actually improving their symmetry now that they're even with using the quad cane. So we can get a little bit more careful phenotyping of our patients. And just as another example of what we can do with this, I was really excited when Anna Tessiatore, one of our PTs, came to me and was wanting to use this technology to look at EMGs and said if she could better understand her patients, she could better treat them. I was like excited, like we can do this. And so this is just some data where, again, we're using this on people in clinic. Now we're putting sensors on the TA, the soleus, recfem, avestis, and lateral hamstrings. And you can see this individual, many trials just in that one little bout. We can see the EMG, we can see it's fairly consistent. We can look at the average, kind of get these more precise snapshots of our patients. And then we can contrast it to someone that's more impaired, that's using a harness support. And we can see a lot more variability in the EMG cycle to cycle. We see a lot more correlations amongst all the channels. And we're still delving into this data, but it's already looking rather interesting. In particular, I think because we're looking at people that are more impaired than are in a lot of studies. And so, we're seeing things that don't necessarily reflect what's reported in the literature. Okay, this is a modeling talk. I haven't had any models, so I'm feeling bad about that. And so now I want to talk a little bit about using deep reinforcement learning and physics-based modeling. But first, why? And I'm going to quote John Oliver from the other day, and he was talking about artificial intelligence. He made the point, the problem isn't that AI is getting too smart, it's that it's still too dumb. And if you use these technologies and you look at them try and perceive people, they make gratuitous errors. And we're really leaving a lot on the floor if we don't instill everything we know about physics and biomechanics deep into the perceptual system. And I was really inspired by these couple of papers by Ye Wan, working on approaches of coupling physics-based simulation to computer vision, and particularly addressing some of the issues if you have a mismatch between an individual's biomechanics and their model and the average property and your physics model you're using. And in particular, I'm really enjoying using this Brax physics engine as well, which is screaming fast. So I can run about 1 billion simulation steps per hour on one GPU. So we can now train over this entire data set and try and learn anthropomorphic heads that make this policy generalized to new people and track their walking. And this is still early work, but here's just examples of people with very different gaits. This is one particular policy then tested on people that were held out during training. On the far right, you can see we've kind of got the model so that it fits the model parameters, so it actually replicates a lot of the kinematics. And we're working on actually training this so it gets the anthropomorphics, the inertia and such, that it actually replicates some of the ground reactions and kinetics. And this runs really fast once it's trained on new data. But I need to know if these systems work. And I really want to get to the point where I can actually compare the head-to-head performance of the original gait transformer and this new physics motivated and constrained system. And for this, I've been putting together a multi-camera markerless pose system. I kind of talk about the specs there. So it's a number of cameras, they're network connected. With this protocol, you can basically synchronize them sub-millisecond, which makes it super easy to deploy them around the hospital. I've got bunch of cameras on back order. We're trying to put them everywhere, including places with stairs and ramps, and I love data. And so it's all running on this pose pipe. So again, we can run large scale analyses managed by a database. But the first step, of course, is make sure we study the person we want to study. And so here you can see me sitting at the computer. There's a person who's clearly using a rolling walker, and behind that, a research assistant taking video with our monocular system to actually compare these two. And once we use this, we say, okay, we're studying the person in blue. I also want to give a shout out to OpenCat, by the way. They're doing some awesome work on making these technologies easier to use and from just smartphones, but I'm going to talk about my system. And anyway, so once we've identified the person of interest, now we want to do those more precise analyses that I described using the bounding box. But once we've done that, the first question I had was, how do you reconstruct the trajectories? And I think for time, because I want to talk about, no, I think I'm okay. So we have these different approaches of reconstructing the trajectories. So the most common is what's called the direct linear transform, where you basically work out what is this one coordinate that's most likely for that one set of points seen from multiple cameras. But that, again, discards a lot of information we know about people, right? So we know that the point should move somewhat smoothly in time. We know that the skeleton length should actually be fairly consistent. And so we can actually then optimize for trajectory with those kind of constraints that I'm showing there. So consistency with the imaging, smoothness, and skeletal constraints. But even going back for a couple of years, whenever I've tried to optimize trajectories, especially if you add a smoothness prior and you're trying to use anything like gradient descent, which is used in modern AI, the time it takes for that smoothness loss to propagate back and forth is proportional to the length of the sequence, and it makes convergence really slow. And so there's these forms called implicit representations that I don't know if any of you have seen these things where you can reconstruct an image and volume and view the volume from different places. They're called NERFs. And so at the core, they learn a function that represents a space. And so I wanted to try using this to learn a function that represents a mapping from time to the trajectories. And so that actually turned out to work quite well. And so here I'm showing some data of a person walking. On the blue and the red key points are the detected key points, and then the 3D trajectories reprojected onto the image. Obviously, the middle is kind of showing the reconstruction. And on the far right, we're now comparing the position of the feet to the gait right data, which are those horizontal bars. And it's basically doing quite well. That large data table, if you want to read through it, basically shows that using some of these newer approaches like Pose trained on this HALP data set using an HRNet algorithm, if anyone cares, it works quite well. We're getting about sub-centimeter spatial resolution. It's got very smooth trajectories and the sort of thing that we'd want to use if we're actually doing biomechanical fits. Which, oh, okay, that's a segue to this slide. And so one of that paper in the upper right, I really want to give a shout out to it, because a challenge for doing biomechanics on computer vision has been that most of the data sets out there kind of stop at the hips and start again at the shoulders. And so everything about your pelvis and torso is completely unconstrained. And this paper did a really awesome job of figuring out how to hybridize across all the different disparate data sets that are out there and leverage their information, account for all the differences in the data collection modalities so that it could actually output a dense set of markers that we'd use in a biomechanics laboratory. Or I don't ever use a biomechanics laboratory, but the smart people that know how to use them. But anyway, so here we're doing 3D reconstructions. You can see the meshes look pretty well, pretty nice. Dr. Collins mentioned the nimble physics and this add biomechanics the other day. And so he was talking about it for marker-based trajectories, but it turns out to work fantastically for this computer vision approaches. And so now we can fit these skeletal models quite nicely. And what's really nice is that it actually detects the things I care about. And so, for example, here's someone that we're running a study looking at the effect of FES to improve ankle control and acute stroke. So normally it'd be very hard to get motion capture during a normal inpatient stay, but now in just 10, 15 minutes, we can bring people down, see them with and without the FES, which is what you're seeing in the upper left panel. And you can see an improvement in their ankle control. And then similarly on the right, we can see the changes in the knee kinematics when we put an AFO on or off. And just because I know there's a number of people that do upper extremity, what's nice is some of these algorithms actually detect all the individual joints, so we can really start to track our movement just as people walk into the room, even getting to the level of tracking individual finger individuation and seeing these kind of tenodesis patterns. So that's fun. I need to still work on getting this coupled to a proper biomechanical model, of course, but okay, cool. The engineer in me is happy that we can measure stuff. That's easier. The clinician in me says no one's better yet. And so I haven't really addressed the 3 questions that we're prompted to discuss. And so this is where I'm going to do that. And I want to talk a little bit about a framework me and my colleagues on the right have been working on that came out of an NIH-funded P2C meeting last year on precision rehabilitation. And I know this is a really busy slide, so I just want to kind of highlight some points on it. So the idea, and is my pointer showing? Yes, good. Okay, so the idea is that first of all, we need to be thinking about things within the ICF framework. Oh, and I should also say this builds on David and Nicholas's computational neurorehabilitation paper. But beyond that, we need to be able to couple changes we see at the level of impairment to changes we see at the level of function and changes at the level of participation. And we're collecting all of this data. You know, people say we need to collect more data. So, okay, fine. But we need to identify what are the actionable biomarkers in this data. We also, as we're giving all these interventions, we really need to track what the interventions are. And there's this rehabilitation treatment specification system that emphasizes how we should document our interventions so we can actually try and sense what are the active ingredients for all this. And when talking about the biomarkers, I forgot to say, I also recommend thinking about it from the perspective of the NIH working group on, what are the diagnostic biomarkers versus what are the prognostic or predictive biomarkers. And as we start collecting this larger data and trying to use these tools from causal inference, constrained by these models, I think we'll start to be able to make progress and really get to the stage where we can actually now identify, the optimal dynamic treatment regime, which is a term that's used sometimes in causal reinforcement learning, but it really captures what we want to do, right? Which is we take all this, we got all these constructs within the ICF, and then we get all these measurements, and based on those, we phenotype a patient. Based on that phenotype, we should actually then have a evidence-based approach to decide what is the best intervention, and then understand how this couples over time. And as a physiatrist, I mostly care about ultimately improving participation and functioning. But as a researcher, a lot of times at early stage, you really need to focus on impairment. And so these kind of models will allow us to bridge between these constructs and bridge over time. And then finally, since it's getting towards the end of the conference, I really wanted to loop back and reference some of the things that have been said during the talk and how this relates to this framework. And so Susan Margulis started this off by talking about the need for more sensing, which I think fits within this. But beyond that, we need to then be able to make sense of that and distill it to these biomarkers. And the digital twin concept really fits within this too, because causal inference, one of the tools it gives us is the ability to answer counterfactual questions. Like if I gave a different intervention to this individual, what would happen? And then Catherine Stahl talked about the appropriate complexity of the models, which, parsing this down is really important. Soke Liu talked about imaging-based biomarkers, which I think really relates to this in the big data aspects. David Lin also kind of addressed talking about things at a different level of the ICF model and finding, brain-based, like depending on where a stroke lesion is, you get changes at different ICF levels or possibly patient-reported outcomes. And then Jessica Allen really talked about getting the minimum set of statistics you need, because really what we want to do is figure out what are the minimum battery of tests we need to give to a person to phenotype them sufficiently to drive this optimal dynamic treatment regime. And finally, I want to thank everyone that helped, the great team, and all the funding sources like Nielsen, American Neuromuscular Foundation, Restore Lab, and Sugar Ability Lab.
Hi, thank you. Great talk. So in reference to your last slide, you talked about using some control policy in order to determine or dictate the interventions, personalized intervention. How do you plan? What is that policy? Are there practical challenges? This is a learned policy. If so, how do you learn it?
Yeah, so that is a very hard problem, but it is a problem people are working on outside of the rehabilitation field. So the general tool is like causal reinforcement, causal reinforcement learning. And so the idea behind causal inference is essentially if you will stipulate a hypothetical causal model, then you can actually fit the parameters on it. And then once you actually have that model with the fit parameters, you can then infer what would be the best counterfactual intervention for a given individual. But this requires a combination of hypotheses, which are the causal model, and data to actually constrain the model. And so this is really more of a longer looking framework of how, as we're collecting all this data and everyone's advocating for we need more data, we also need tools that are deterministically going to make people better as a result of that. And this is where I think that comes in. And then the policy is not referring to like healthcare policy or anything like that. That's more of a technical jargon from the reinforcement learning field, which basically means given some state, a policy is what determines the action you will take. And that is a learned function for rehabilitation.
Hey, James, that was a great talk. I really liked your last couple of slides about sort of your vision for big data in medicine. My question for you, as someone who's thought about this a lot, is how good do our models have to be in rehab to be able to make actionable choices? We know for example, on the upper extremity, we have things like the PrEP algorithm, which are about 80% good. But I'm wondering, in most of other fields in most of other fields of medicine, our biomarkers are built off things like blood tests. And here we're talking about modeling behavior, which is much more variable. And so I'm wondering, as you think about this, how good do our models have to be able to incorporate them into clinical practice?
Yeah, that's a really good question. And I mean, I think my answer is going to be, again, very based on the fact I'm a physiatrist. So I would want to so first the question is like, how well does your model fit the data, right? When you get holdout data, how well does it fit that? When you get data from different sites, how well does it generalize, right? So the more AI is in it, the more you really need to vet every aspect of it. Then the question becomes, when should you really start to use, let's say you fit this policy, when should you actually use that, right? Well, at first it's going to be a human in the loop looking at that saying like, is that the therapy plan that makes sense? And if it produces nonsense outputs, you probably shouldn't do that. And then I think the other part of it would be, this model should give us the ability to make predictions that if I did intervention A versus intervention B, this would be the ultimate outcome on a functional or a participation measure. And so if that's going to produce a minimally clinically important difference, that would be when it's a really good time to start thinking about doing that. If not, it's time to keep pushing on the interventions.